All right, last time we talked about Guillain Barre syndrome. Let's go over it again. So we said it's a post-infectious disorder. It produces an ascending paralysis. You might have some sensory findings. So classically from the toes, the hands, and then it ascends. And we said that it's a big deal because it can get to your lungs and your diaphragm, your chest muscles, and you can stop breathing. So that's a big deal. And I've been reading that about 30% of people with Guillain Barre syndrome actually need to have mechanical ventilation. So it's quite a lot of people. The post-infectious thing was Campylobacter. We need to know that for exams. We need to know that it's predominantly supposedly motor, but a lot of people have these sensory symptoms. And what do you do for these people? And it's a really big one. So the key thing is IVIG. If you get them early, you give them IVIG, and you can also do plasma exchange. This significantly reduces the duration and the severity of the disease. But let's go back to the respiratory complaints because that is the big one. So at the bedside, how do you determine whether this person needs to have mechanical ventilation? Well, you can look at them, and if they're not breathing, they need mechanical ventilation. But before they get to that point, one of the bedside tests you can do is this counting test, where you get the patient to take a full breath in, all the way in, and then count at about 2 numbers per second. 1, 2, 3, 4, 5, out loud, 6, 7, 8, 9, 10, as far as they can. Most normal people can get to about 50. If you're less than 20, then your capacity is significantly reduced. And if you do it serially over hours, days, and it's going down, that might be more indication that this is getting worse and that you might have to ventilate them. So these are the key things. IVIG. You want to give that early. Steroids are out right now. Steroids, we don't think are working. And this count test, the 20-second count test, is a really good bedside test to help you determine whether this person needs to be ventilated. Now, what are some of the diseases that this can mimic? And that's why it is a foil. There's a bunch of them, actually. So hypokalemia, periodic paralysis, for example, botulism, myasthenia gravis, transverse myelitis, spinal cord injuries, a whole bunch of these things can make you think about Guillain Barre. So let's do a question again. A patient comes in and they've got progressive weakness, started in their toes and it's moved up, it's now in their thighs. And there's a lumbar puncture and it shows what? What is the classic finding on the lumbar puncture of Guillain Barre? We talked about it last time. So it's an increase in protein, but a normal cell count. And that's classic, right? But that can take a while to sort of occur. Usually, if you've got, say, a bacterial meningitis, what do you get? You get an increase in protein, yes, but your cell count also goes up. And so that's how you might differentiate it in the little quizzy quiz. If they're sort of trying to take you down the garden path, is this a CNS infection? So there it is, Guillain Barre syndrome, a foil. You need to know about it. It's big, it's huge, it's large. Get the LP, look for those changes. Often it's a diagnosis of exclusion, and the IVIG is the key intervention, and then the respiratory stuff. And you can also do much more sophisticated things, like you can have the respiratory therapist come down and see how much force they can breathe in, all that stuff. But that 20-second count test is sort of the classic for Guillain Barre. Oh, we also remember we talked about the variants. There's a bunch of variants. One of the variants we talked about is the Miller-Fisher variant, which is from the bulbar muscles. So your eyes go googly and you can't swallow properly. You might not be able to breathe properly. And there's another thing I should say, which is really important, actually. I almost missed this. And that is the fact that they can get autonomic dysfunction. So their blood pressure can go sky high and then go down. And that can be a real issue. And so if there's a question about that, the treatment is usually to treat the hypertension. And you should use something that's very short-acting and IV. Something very short-acting and IV, like Esmolol. You don't want to use a long-acting agent because their blood pressure might drop down again. So if it's dropping, then you can turn off the Esmolol. So that autonomic dysfunction, which classically presents with these fluctuations in their blood pressure, can also be part of this syndrome. All right, herb it out. The show is Invictus Reviews. This is the free podcast. You're either watching this on the YouTubes or you're listening to it on the podcasties. And we're going to be coming out with the full show, the full board review course, hopefully in the first quarter of next year. But we'll keep this thing going till then. And if you're an emergency medicine resident listening to this, you're going to have your in-service coming up in a couple of months, February. And the in-service scores for emergency medicine have been going down. It used to be 95% of people were passing, and now the pass rate is only about 80%, 75%. So we need to be practicing our boards again, and that's what this whole thing is about. So the first thing I want you to do, if you're interested, in my opinion, is go get one of the peer tests and do it from beginning to end. Give yourself a score, then look at the different categories and start studying in the areas of weakness. But also for now, we are going to be going over these foils, which are so important on the test. You need to know these foils. You need to know them well because they'll come up in multiple different STEM questions. And if you know what these diseases present like, you'll be able to get these right real fast, mate. All right, Herbert out. Invictus Reviews. Talk to you soonsies. Dunsey.